So, imagine for a second that you are building a human organ from scratch.
Like literally from nothing.
Right, from nothing. Complete with flowing blood, communicating cells, all sitting on a piece of plastic that's maybe, I don't know, the size of a flash drive.
It sounds like pure science fiction, honestly.
It really does. But now, imagine using that exact same logic to regenerate the most sensitive, nerve-dense tissues in the human body, like coaxing them to literally heal themselves.
Yeah, and that is actually the reality of where bioengineering and clinical medicine are colliding right now. I mean, we are looking at a fundamental shift in how science approaches mucosal and epithelial barriers.
Which are basically the tissues that line our internal cavities, right?
Exactly, the linings of our organs, all of that.
Well, we are diving deep into all of it today. And welcome to the deep dive, by the way. We've got a really fascinating stack of sources to unpack for you, looking at two totally different but deeply connected worlds.
Yeah, on one hand, we have these real-world clinical studies from aesthetic gynecology.
Right, showing how doctors are currently using blood plasma, structural fillers, and even shock waves to repair highly sensitive tissue in living patients.
And then on the other hand, we are transitioning straight into the lab to look at the bleeding edge of tissue engineering. We've got this incredibly dense, brilliant doctoral thesis by Daniel Vera Ibanez.
The gut on a chip one.
Yes, exactly. Bioprinting a 3D gut on a chip, which solves some just massive problems in how we test these human barriers.
So our mission today is to basically uncover how science is manipulating and repairing these tissues, starting at the macro level in clinics and then zooming way down to micro level engineering in the lab.
It's a huge journey.
It is. So let's start with how doctors are essentially hijacking the body's natural healing mechanisms today. I want to talk about this treatment known as the O shot, or orgasm shot.
Right, which is being used to treat female sexual dysfunction, anorgasmia, and even stress urinary incontinence.
And the whole foundation of that treatment is platelet-rich plasma, or PRP, which is wild because you aren't introducing a foreign drug.
No, not at all. You are using the patient's own biology.
Right.
The practitioner draws about 10 to 20 milliliters of the patient's peripheral blood. So it basically just looks like a standard blood draw at your annual physical.
And then they take that blood and they just pop it into a centrifuge.
Yeah, they spin it at crazy high speeds. And the physics of that centrifuge forces all the heavier red blood cells to sink right to the bottom,
Separating them from the plasma.
Exactly. So what you're left with is about 5 cubic centimeters of this, like, translucent golden liquid. That is the PRP. And it is just overwhelmingly dense with platelets.
Okay, so you get this golden liquid, but from what I was reading, it's basically dormant at that stage, right?
Too much.
Like, if you just injected that liquid straight back into the tissue, nothing much would actually happen. So how do they wake it up?
Well, they actually have to mimic a trauma.
Oh, wow.
Yeah, the practitioner adds a really specific chemical trigger to the plasma, usually just a tiny amount of calcium chloride. And when that calcium hits the platelets, it activates what we call the thrombin cascade. The platelets are suddenly tricked into believing that, like, a massive tissue injury just happened.
So they freak out.
Right, they undergo what's called degranulation.
Degranulation meaning, wait, are the platelets physically bursting open?
Basically, yes. They are releasing their internal granules, which are essentially just payloads packed with growth factors and cytokines.
And those are the chemical messengers that tell the body to heal.
Exactly.
So it's kind of like creating a highly concentrated biological fertilizer.
That is a great way to put it, yeah.
By injecting this activated plasma, you're sending this blaring signal to the native stem cells, just screaming, hey, we need you to build brand new infrastructure in this exact spot right now.
That is highly accurate. You are forcing a localized regenerative response in tissues that, might be suffering from atrophy or lack of blood flow.
Right.
But once that chemical trigger is added, the plasma starts turning into a stiff fibrin gel very quickly, usually in under 10 minutes. So it has to be injected into these specific anatomical targets, like, immediately.
And the injection sites in these clinical protocols are hyper-specific.
Oh, very much so.
They typically inject about 4 milliliters into the anterior vaginal wall.
Yeah.
Right, like targeting the area between the vagina and the urethra.
Yes.
And then they inject another 1 milliliter directly into the clitoris, sometimes dividing that milliliter evenly around the 4 cardinal points of the clitoral shaft, so 12, 3, 6, and 9 o'clock.
And some practitioners even take it a step further. They mix stromal vascular fraction, which are stem cells derived from fat in with the PRP, to make that biological fertilizer even more potent.
Wow.
But ultimately, the physiological goal is identical. Those growth factors recruit stem cells, they stimulate fibroblasts to generate new collagen and elastin, and crucially, they promote neovascularization.
Meaning the formation of entirely new blood vessels.
Precisely. You are building a brand new vascular bed to restore natural blood flow and sensitivity over time.
Wait, hold on a second, though. I was reading through these fluid volumes. 4 milliliters here, a milliliter there. We are talking about injecting up to 5 milliliters of fluid into an incredibly confined, highly nerve-dense space.
Yeah, it's a lot of fluid for that area.
Doesn't pumping that much liquid into such a tight area risk causing, I don't know, pressure trauma? Like, it seems like they could crush the exact nerves they are trying to revitalize.
Well, the spatial constraints are a massive challenge for sure, and the clinical protocols are designed entirely around mitigating that exact risk.
Okay, how?
To avoid mechanical trauma, they use extremely fine needles. We're talking 27 to 31 gauge. To give you an idea, a 31 gauge needle is practically the thickness of a human hair.
Wow. Okay, so the needle itself is barely leaving a footprint, but what about the actual fluid pressure once it's inside?
That all comes down to the injection technique, which is called hydrodissection. They aren't injecting the fluid directly into the nerve bundles.
Oh, they aren't.
No. The needle is placed very carefully in the subcutaneous or submucosal layers, the empty spaces between the distinct layers of tissue.
I see.
And they inject at an agonizingly slow pace. The fluid acts like a gentle wedge, just softly separating the tissue layers and creating a temporary pool. So it bathes the neurovascular complex in those growth factors without crushing the nerves against the fascia.
That makes a lot of sense. And the sources also mention they have to aspirate before they inject a single drop. What does aspirating actually mean in this context?
It's a crucial safety check. The practitioner basically pulls back slightly on the plunger of the syringe before pushing any fluid in.
To see if blood comes out.
Exactly. If
Yeah.
blood enters the syringe, it means the tip of the needle is inside a blood vessel, and they have to reposition immediately. You want this gel in the tissue, not traveling freely through the bloodstream.
Right, definitely not. So then the body absorbs the fluid portion relatively quickly, leaving just that fibrin matrix and the growth factors behind to do the slow work of rebuilding the cells.
Which takes weeks or even months.
But sometimes biological regeneration isn't really what the patient needs in the moment. Sometimes there's a need for immediate structural support.
Or a need to manage pathological physical stress, yeah. We see this shift in the literature when doctors move away from plasma and start using structural and mechanical interventions, like hyaluronic acid or HA fillers.
Right, HA fillers. If you follow aesthetics, you usually hear about HA fillers being used to, like, plump up lips or contour cheeks.
Sure.
But in these gynecological protocols, doctors are using HA to restore lost volume to the labia majora and to camouflage the clitoral hood to prevent painful friction.
And the defining characteristic of hyaluronic acid is that it's a hydrophilic gel. It aggressively attracts and binds to water molecules.
So injecting HA isn't like putting in a solid, inert piece of silicone. It's more like injecting a microscopic sponge into the tissue that actively pulls surrounding water toward itself to create volume.
That hydrophilic sponge effect is incredibly useful for creating structural space, but it's also the source of the strictest clinical warnings in the entire protocol.
Because it keeps expanding.
Exactly. Because the HA continues to pull in water and expand over the weeks following the injection, the volumes have to be managed with extreme caution. For the labia majora, doctors generally use between 0.5 to 2 milliliters per side.
But the clitoral hood is a totally different story. The expert consensus guidelines are incredibly rigid on this point. I remember seeing this. What is the absolute maximum recommended fluid volume they can inject into the clitoral hood?
It is exactly 0.5 milliliters per injection point. You cannot exceed half a milliliter.
Half a milliliter is tiny. Why is the limit so insanely strict?
It goes right back to your earlier concern about pressure, actually. But in this case, we are specifically worried about ischemic pressure changes.
Ischemic meaning lack of blood flow?
Yes. The anatomy of the clitoral hood is incredibly delicate and tightly bound. So if a practitioner injects more than 0.5 milliliters, or if that hydrophilic gel expands too much, the sheer physical pressure of that gel inside the confined space will compress the surrounding capillaries.
Just pinching the blood vessels completely shut.
Exactly. Ischemia means a restriction in blood supply. If you crush those capillaries, you starve the tissue of oxygen, which can lead to necrosis or tissue death.
Oh, wow. That's terrifying.
It is. That's why the zero point 0.5 milliliter maximum is a hard limit to prevent those local ischemic pressure changes.
And the sources also note that doctors advise patients absolutely not to massage the area after HA injections to prevent severe edema or swelling.
Right, leave it alone.
And the placement is critical too. If a practitioner goes too deep in the lower third of the labia, they risk hitting the perineal artery. I actually read one documented case study in the literature titled Mimicking Bilateral Vulvar Testicles.
Ugh, a horrifying title.
Truly awful. And it happened because the filler was placed so poorly, too deeply, and in the completely wrong volumes. The gel basically aggregated into these solid lumps that completely distorted the anatomy.
Yeah, it's a stark reminder that while these therapies are non-surgical, they demand profound anatomical precision. Now, beyond injectables like HA, doctors are also using pure mechanical energy to manipulate tissue function. Like, there's a German patent detailing a pen-shaped vacuum device.
A highly localized vacuum pump to just draw blood into the area. But they explicitly note the vacuum pressure has to be engineered to stay lower than the patient's systolic blood pressure. Why that specific threshold?
Well, systolic pressure is the maximum pressure your heart exerts while beating. If the vacuum pressure exceeds that, you aren't just coaxing blood into the arteries, you're applying so much negative pressure that you can actually rupture the capillaries.
Causing massive bruising and long-term vascular damage.
Right. By keeping it below the systolic threshold, the device safely encourages engorgement without the trauma.
But the body's vascular system is complex, and sometimes it just goes haywire on its own. The literature details the exact opposite problem: persistent clitoral priapism, unwanted, painful, prolonged engorgement that just won't go away.
It is a rare condition, but incredibly distressing for the patient. The initial treatment is usually pharmacological. Following American Urological Association guidelines, doctors will inject a drug called phenylephrine directly into the tissue, usually at a dose of 100 to 500 micrograms per milliliter.
How does phenylephrine actually solve the problem, though?
It's a powerful vasoconstrictor. It basically mimics the signals of the sympathetic nervous system, forcing the smooth muscle in the blood vessel walls to clamp down aggressively.
Okay, so it squeezes them shut.
Yes. This restricts arterial inflow and forces the trapped blood out of the tissue.
But when drugs fail, things get really interesting. There was a case study highlighting a patient with persistent priapism who was successfully treated using extracorporeal shockwave therapy, or LI-ESWT.
Oh, yes! The shockwaves.
The doctors used a device to deliver 2,000 acoustic shockwaves per session directly into the tissue, and it completely resolved the condition.
How do sound waves cure persistent engorgement? I mean, are we just inflating and deflating balloons here? Well, you'd think so, but no. Shockwaves are not just a physical massage, they cause a biological cascade.
How so?
The acoustic waves pass through the tissue and create controlled microtrauma at a cellular level. In a case of priapism, the tissue often has fibrotic, scarred microstructures that trap the blood. The shockwaves physically break down that fibrosis.
Well, interesting.
And furthermore, just like PRP, the microtrauma signals the body to release endothelial growth factors. This remodels the vascular bed, allowing the blood to drain and flow normally again.
It's actual structural remodeling through acoustic physics.
That's wild.
But, seeing these incredible results in a clinic, whether it's through blood plasma, HA sponges, or acoustic shockwaves, it raises a massive problem for researchers.
It really does.
If you're developing a new treatment, say a new chemical filler or a new drug to treat sexual dysfunction, you can't exactly just inject experimental compounds into a patient's most sensitive, nerve-dense tissues to see what happens. The risk is completely unacceptable.
And historically, the alternative hasn't been much better. For decades, scientists have tried to study these complex barrier tissues by growing human cells in the lab on flat, stiff, two-dimensional petri dishes or on, semi-porous pieces of plastic.
Which is completely useless because human tissue isn't flat or stiff. A petri dish doesn't behave anything like a living, stretching, communicating human organ.
Exactly. And that immense limitation is the core problem solved in Daniel Varibanez's doctoral thesis.
Yes, let's get into the lab side of things.
He focused on the human gut, which is arguably the most complex mucosal and epithelial barrier in the body. The human intestinal lining is deeply three-dimensional. It's covered in these microscopic, finger-like protrusions called villi, and deep valleys known as crypts.
So if a standard laboratory test is like studying a flat 2D map of a city, What this thesis describes is building a fully functioning 3D diorama of the city, complete with flowing rivers, complex architecture, and inhabitants that actually talk to each other.
That is the perfect essence of a gut on a chip. But the engineering required to transition from a flat piece of plastic to a living 3D diorama is just mind-boggling. First, they had to invent a biomimetic hydrogel to replace the stiff plastic petri dish entirely.
A hydrogel being a microscopic scaffold made mostly of water and polymers. How did they formulate it so the cells would actually like it?
They had to combine two very different materials to strike the perfect balance. They used a tough synthetic polymer pegda to act as the structural skeleton.
Giving the hydrogel mechanical stability so it doesn't just dissolve or collapse under pressure.
Right, but biological cells hate synthetic plastic. They have nothing to grab onto. So they mixed in a natural gelatin-like material called gelme.
Ah, okay.
This natural component provides the biological binding sites that allow living cells to attach, thrive, and survive inside the gel.
Okay, so you have this perfect hybrid gel material,
Mhm.
but how do you actually shape it into those tiny microscopic 3D finger-like villi? You can't exactly pour it into a tiny mold.
No, use light.
It
Yeah. They utilized a microfabrication technique called visible light 3D bioprinting, specifically DLP-SLA. A specialized projector shines highly specific patterns of visible light into a vat of the liquid hydrogel mixture.
oh, wow.
And the chemistry of the gel is designed so that wherever the light hits it, the liquid instantly cross-links and hardens into a solid.
So they are essentially curing the gel layer by microscopic layer just using light.
Yes, and doing so allowed them to successfully print 3D pillar structures that perfectly match the physical dimensions of real human intestinal villi.
Okay, so the 3D architecture is built. Now they need the inhabitants. And this is where the compartmentalization aspect of the thesis just blew my mind. They didn't just sprinkle cells on top of the gel and hope for the best.
Not at all. They embedded stromal cells, specifically 3T3 fibroblasts, which are the connective tissue cells we talked about earlier in the clinic, deep inside the hydrogel itself.
Inside the gel.
Yes. Then they engineered the chip to pump fluid continuously around the structures to simulate the mechanical shear stress of blood flow and digestion. And finally, they grew the epithelial cells, the CACO2 barrier cells, on top of the hydrogel pillars.
But why go through the crazy trouble of putting cells inside the gel and different cells on top of the gel?
Because that is how human tissue actually works in our bodies. Older organ chips only ever use the top layer of epithelial cells, but in your body, that top layer relies entirely on the underlying stromal cells for survival instructions.
Oh, they talk to each other.
Exactly. By embedding the fibroblasts inside, the hydrogel acts as a living, artificial extracellular matrix. The stromal cells inside and the epithelial cells on top can send chemical gradients to each other through the gel. They are constantly communicating, maintaining the integrity of the barrier, just like they do inside you and me.
Okay, so you've built a living, breathing microorgan on a piece of plastic. But that leads to the final massive hurdle. If you have spent all this incredible time, money, and effort to bioprint a 3D living tissue on a chip, how do you measure its health without accidentally destroying it?
It is the great paradox of biology. You want to know how tight the barrier is? Like, are the epithelial cells locked together properly to prevent toxins from leaking through?
Right, because in a healthy mucosal barrier, the cells are glued together by what are called tight junctions and adherens junctions. They act like biological mortar between the cellular bricks, creating a waterproof seal.
To measure the strength of that microscopic mortar, the team integrated a technology called TEER, which stands for transepithelial electrical resistance. It relies on a principle called electrochemical impedance spectroscopy.
Okay, let's translate the heavy science there. How does it physically measure the cells?
It passes a tiny, harmless electrical current right across the cellular barrier. Cell membranes are made of lipids, which are essentially electrical insulators. Because the electricity can't easily go through the cells, it is forced to travel between the cells, squeezing through those tight junctions.
So it's like trying to find a leak in a dam. You push water against it, and if the mortar between the bricks is weak, the water slips through easily. But if the mortar is strong, it resists the water. In this case, the electricity is the water.
That's a great analogy. If the tight junctions are strong and healthy, they heavily resist the electrical current. The higher the electrical resistance measured by the machine, the tighter and healthier the biological barrier.
The engineering required to pull this off is just stunning. They managed to integrate microscopic, platinized gold electrodes directly into this 3D bioprinted chip, right alongside the living cells.
And because of that, they were able to monitor the barrier forming continuously over 2 full weeks.
Now, if you are listening to this and wondering why scientists don't just use a high-powered microscope or a chemical dye to look at the cells and see if the barrier is tight, why go through the trouble of wiring hydrogel with gold?
Because it fundamentally changes what kind of science you can do. If you use chemical dyes or immunofluorescence to look at tight junctions, you generally have to fix the cells.
Fixing meaning,
Yeah.
using chemicals like formaldehyde that permanently freeze the cellular structures in place.
Which kills them instantly. You get a beautiful high-resolution photograph of the cells, but the experiment is entirely over. You only get a single snapshot in time. TEER, however, provides a non-invasive, continuous readout.
So it's the difference between looking at a photograph of a car crash versus having a live video feed of the highway.
Exactly. With the gold electrodes and TEER, you can watch the tissue grow and strengthen over several days. You can then introduce a toxic drug or an experimental treatment and watch the electrical resistance drop in real time as the barrier breaks down. Then you can flush the drug out and watch the live data to see if the tissue recovers its resistance. All without ever touching or harming the living cells. It allows for dynamic longitudinal studies that were literally impossible a few years ago.
When you step back and look at the whole picture, the progress is just staggering. We started this deep dive at the bleeding edge of clinical medicine, looking at how doctors are forcing the body to heal itself.
Right, using the thrombin cascade to turn blood plasma into regenerative fertilizer.
And strictly managing precise limits of hyaluronic acid, remembering that absolute 0.5 milliliter maximum for the clitoral hood to prevent ischemic tissue damage.
We saw how they managed structural and mechanical stress in living patients, and then we zoomed all the way down to the microscale, looking at the incredible lengths bioengineers are going to in order to replicate those exact same environments.
Building synthetic natural hybrid hydrogels, bioprinting them with light, embedding them with communicating cells, and wiring them up with gold electrodes.
It's all connected.
It really is. Whether you are curious about the future of wellness, longevity, and how we will repair physical trauma, or you're just fascinated by how pharmaceutical companies are going to test the next blockbuster drug. This convergence is the future. The blending of cellular biology, material science, and microengineering is completely bridging the gap between clinical guesswork and perfect laboratory modeling.
We are entering an era where we no longer have to guess how a complex human tissue might react to a physical or chemical stressor. We can model it, observe it, and measure it in real time with unprecedented precision.
Which leaves us with a final, slightly provocative thought to ponder long after this deep dive is over.
Oh, I like these.
If researchers can currently bioprint a gut on a chip that perfectly mimics intestinal absorption, and doctors and clinics can successfully inject growth factors to regenerate nerve and vascular tissue for sexual dysfunction, how far are we from a genital on a chip?
That's a wild thought.
Right. Could we soon be studying treatments for tissue atrophy, anorgasmia, and nerve regeneration entirely in the lab? Imagine testing hundreds of experimental therapies simultaneously on a microchip, entirely removing the immense risks of early-stage human trials on such delicate anatomy. The blueprint is already there.
The foundational engineering principles have absolutely been established. I mean, it is just a matter of time, funding, and targeted research before highly specialized mucosal models like that become a standard reality in the lab.
It's going to change everything. Thank you so much for joining us on this deep dive. Keep asking questions, keep exploring, and we will catch you on the next one.